Hello, my name is Michelle Fravel. I am a clinical assistant professor at the University of Iowa College of Pharmacy. I also practice at the University of Iowa Hospitals and Clinics as an ambulatory care pharmacy specialist. And two of the clinics that I spend time in are the chronic kidney disease clinic and also our geriatric clinic as well. So today I am going to be focusing on kidney function and medication dosing adjustments in the older adult. In terms of conflicts of interest, I have nothing to disclose. All right, so in terms of learning objectives, I've outlined a few key points that I hope to cover today, so I will read through those to kind of set the stage for the rest of my talk. To start off with, I am going to describe the impact of age on kidney function. Next, dive into various ways of estimating kidney function, specifically looking at older adults. The next topic, identify medications that require dose reduction or should be avoided altogether in older adults with reduced kidney function. And then as a final step, identify appropriate medication doses for older adults based on their individual kidney function. Okay, so we will dive right in. So whenever I think of this topic, this comes into my head. So you will hear a lot of healthcare professionals say, oh, you know, they look at a patient's chart and they're an older patient, and you'll hear this. So it's not real kidney disease, it's just the normal aging process. And so I want to address that today. That's the first thing. So what do we mean? I mean, healthcare professionals mean when we say that. And so let's start by looking at the data. So when we look at very old studies, so I've cited two studies here, one, the first being 70 years old, and the second almost 50 years old, studies that have looked at this very question. So if we follow patients for decades and decades, what happens to their kidney function? And so in these two studies, just to kind of boil it down and get to the bottom line, what we have concluded is that the GFR declines by about 8 mils per minute per decade after the age of 40. GFR meaning glomerular filtration rate. And so this shows us that, yes, in fact, with normal, healthy, aging adults, we do see a normal decline in kidney function with time. So why is that? So what happens as we age with our kidneys? So just like any other organ, there are actual changes that occur that do end up impacting the function of the kidney. And so I've separated this into two different categories here. So the top being microstructural changes and the bottom being macrostructural changes. And just to kind of, again, summarize these or put these into terms that we can all easily understand. So sclerosis and fibrosis. What we see is hardening of the arteries in the kidney. We see scar tissue developing with time. And then the last one, an actual decrease in the number of nephrons. So if you recall back to anatomy courses that you may have taken a long time ago, nephrons are the filtering body of the kidney. There are approximately 1 million nephrons in each kidney. And with time, and these are studies that have simply looked at series of autopsies, it's been found that we just lose the number of nephrons. So it's estimated that about 7,000 nephrons are lost each year of life. In terms of the big picture, so macrostructural kidney changes, information from this is pretty robust in terms of looking at the kidneys, healthy aging kidneys. And this is attributed to the fact that we have a lot of healthy kidney donors that, despite having no kidney disease themselves, undergo a lot of imaging just to ensure that indeed their kidneys are healthy and that they are good candidates to donate a kidney. And so from that, we've learned that in these healthy, normal aging patients, that cysts develop and grow. So again, no signs of kidney damage, but with time, cysts develop. Also, we noticed just a change in the overall structure and composition of the kidney. So the cortex is kind of the outer portion of the kidney, and it's been seen that with time that the size of the cortex decreases. And so to sum things up and kind of go back to that original question, so if we ask ourselves, do older patients with reduced GFR, glomerular filtration rate, have true CKD? I think we need to just reframe that question. So what I would suggest is that instead we ask, how does the reduction in GFR that we see due to healthy aging impact my approach and care for this patient? And so I think when we as healthcare practitioners are saying, oh, it's just aging, it's nothing, we're referring to the fact that, for example, if we see a patient who is 82 and their GFR is reduced, so normal GFR being 60 or above, and we see it coming in at maybe a low 50 level. In contrast, if we see a 40-year-old patient with that same GFR, so a lower level at maybe a low 50, we approach the care to those patients very differently. And so we have a lot of concerns for the younger patient progressing to a level of kidney disease with time that would be very concerning. And so that first question, are our patients at high risk for ESRD, so end-stage renal disease, essentially meaning the need for dialysis? So for our older patients, our 82-year-old in this example with a GFR of 50, no, we don't really have that concern. It's very unlikely that in the time that she has left that she'll progress to a point where she needs to receive dialysis. In contrast, the example of the 50-year-old patient, we do have high concern for that. And so we monitor that patient more frequently. We have them begin to see nephrologists. We monitor specific labs. We start to have education about what it will look like for them in terms of needing dialysis potentially in the future. And so that, I think, is what this question is truly getting at. The second point is very similar. So are older patients with reduced GFR at high risk for secondary renal complications? And so by that, meaning the bone and mineral disorders that develop as a result of having kidney dysfunction or anemia that develops because of kidney disease. And again, I would say for our older patients, no, that's not likely the concern. It's unlikely that given their age, they will live long enough to start to experience those complications. And so I think what we're saying when we ask this question is, should we be labeling these younger patients and older patients the same? And that's where a lot of the controversy lies. And so maybe the conclusion is that there are differences, and we require an individualized approach for how we look at older patients with reduced GFR. Having said that, I think the last point is one that we're going to focus on quite a bit today and requires quite a bit of attention. And so in my last bullet here, are older patients with reduced GFR in need of medication dosing adjustments? And I would argue that yes, equally to that younger patient. So medications don't care what caused the disease or the decline in the GFR, and they don't care what age the patient who's experiencing the decline in GFR are. So if a medication is eliminated from the body by the kidneys, and there's a reduction in the ability of the kidneys to do that, then we really have to be thoughtful about how we dose those medications. And again, that's true for anybody who has a reduction in GFR. And so, as I mentioned, the rest of this talk is really going to focus on that. So, as we start to address this question, the first thing that I think of is, is this common? So do older patients who have reduced GFR commonly take medications that are eliminated from the body by the kidney and may require dosing adjustments even at the kind of beginning stages of decline in GFR that we see in older patients that have healthy aging? And so I would say the answer to this is yes. And we have a really great guideline that helps us identify these specific medications. And so what I've listed in this slide is a clip or kind of an image from the American Geriatric Society 2019 Beers criteria. So for those of you unfamiliar, the Beers criteria is a nice guideline that gives us instructions about medications that we should be cautious of when we use them in older patients. The 2019 version of this criteria is the 6th iteration. This was first published in 1991. And since 2015, so the last update prior to the 2019 update, there has been a really handy chart that is specifically geared toward looking at this question about kidney disease. So if you look at the title of this table, so Table 6 in the 2019 version, it is the American Geriatric Society Beers criteria for medications that should be avoided or have their dosage reduced with varying levels of kidney function in older adults. And the next layer there shows you the level of detail that's provided. So not only is a specific list of medications suggested, but there's also rationale for why we need to be cautious about these medications in patients with reduced renal function, and then recommendations. And so I would like to go through this in a little bit more detail. And so this table you'll see here, I have pulled out the 23 medications that were identified in the 2019 criteria. And what I like about this list is that it's manageable. It seems like something that you really can take a look at and start to become familiar with these medications. And hopefully when you see them on a medication list of an older adult patient that you're caring for, it kind of sets off an alarm for you or makes you think twice about the dosing that you're using for that patient. In addition to 23 medications, they've separated this into 5 different categories. So you'll see we have anti-infectives, cardiovascular medications, medications that impact the central nervous system, gastrointestinal medications, and then last, medications that are used to treat hyperuricemia. And so I will show you one more slide that shows you the full level of detail that these criteria provide. And so if we're looking at this example, these are the 2 medications used to treat hyperuricemia. And so listed there are colchicine and probenecid. So what I think is maybe most helpful in this table is the rationale piece. And so it tells you not only are these medications that are eliminated by the kidneys and maybe require a dose adjustment or avoidance, but they tell you why. And so for colchicine, we have a concern about buildup of that medication. So if you're not ridding yourself of that medication through your kidneys, then you can have accumulation. And then we worry about gastrointestinal side effects and other severe side effects that can develop. With probenecid, it's quite a different story. So we're not necessarily worried about accumulation of the drug and side effects. We're worried about the fact that it just won't work. It simply is ineffective once you get to lower levels of kidney function. And so again, this is a very manageable table that can be very practical and helpful when you're caring for older patients with reduced kidney function. So as we transition to this next topic, I want to pay attention to that second column. So you'll see that these recommendations are based upon the level of kidney decline. And so how far of a decline in GFR or kidney function does your particular patient have? And that will really drive how you approach using that medication in that particular adult. And so that brings us to our next topic. So how do we make that determination? And so what do we look at to decide what the actual renal function that our patient has? And so I'm going to start here. This is veering a little bit away from a specific focus on older adults, but kind of getting back to the basics a little bit and going through what we know about assessment of renal function. And so in this slide, I've outlined 3 primary ways that we go about assessing a patient's renal function. So the first is measuring the glomerular filtration rate. The second approach we can use is to measure creatinine clearance. And the third is to estimate these. So we can estimate both the creatinine clearance and the GFR. So to go through these briefly, what is the process involved to measure these? So measure both GFR and creatinine clearance versus estimation. So starting with GFR, how do we get a measured GFR? So this is a pretty involved process. So this involves admitting a patient and administering a substance to them that is almost 100% eliminated from the body through GFR, so through glomerular filtration. We do have a couple of those products that we can administer, so medications. Iothalamate and inulin are 2 examples of products that we can give to patients to administer via IV, collect their urine, and do mathematical calculations to come up with a measured GFR, glomerular filtration rate, for our patients. So the drawbacks, I think, are a little bit obvious. We check kidney function every single time we see a patient, and so you can imagine that this isn't exactly feasible. At this point, this method of measuring GFR is really limited to research studies because patients don't want to have IVs. It's expensive and invasive and costly. In contrast, we can measure creatinine clearance. And so in contrast to measuring a GFR, creatinine is a natural byproduct of muscle breakdown. And so you don't have to administer a substance to a patient. We can simply collect their urine. The nice thing about creatinine is that it's almost exclusively eliminated by the body through glomerular filtration. There is a slight exception. There is some elimination via proximal tubule secretion, and so there is warning that if you measure creatinine clearance, it might provide a slight overestimation of the true glomerular filtration rate. However, that's pretty minor, and so this is a really good way to get a feel for how well your patient's kidney is functioning. The drawbacks, this too is a bit timely, and so this requires urine collection for a 24-hour period. So you have to send your patients home with a large jug and instruct them to collect their urine for a 24-hour period, which again is time-consuming and is one of the major drawbacks to doing this routinely for practice. So what do we do routinely in practice? Well, we estimate these, and so you often see a GFR in the patient's chart that is automatically populated when you measure a serum creatinine. And so where does that come from? Likely, the charting system is using an equation. And so they are likely using the MDRD equation, which is the most commonly used equation to estimate GFR. And so the equation is listed there. Not anything that you would ever, hand calculate, but sometimes it's good just to see what is being done behind the scenes for you. And how was this equation developed, I think, is something to think through. And so this was a study of 1,070 total patients with a mean age of 50 years. And essentially what they did is they measured GFRs for all of these patients. And so administered a substance like inulin or iothalamate, collected their urine, found measured GFRs, and then constructed this equation to find a pretty good fit. And so the question was, can we take a simple blood sample and get a blood level of creatinine and come up with a mathematical equation that will help us predict that measured GFR without having to go through that process? And they did. And this is the equation that we are still using pretty much across the board today. And as you can see, this was a study from 2000, so about a 20-year-old study, and we're still using this equation today. The factors in the equation are important to consider, so it involves the use of serum creatinine, so a blood level of creatinine, the patient's age, gender, and then race as well. Similarly, we have an equation that we use to estimate creatinine clearance, and this is an equation very widely known. So Cockcroft-Gault is this equation. Very similarly, just like the study I outlined previously, this was developed in a cohort of patients, so 249 total patients. And what they did is measured creatinine clearance, so gathered 24-hour urines, measured it, came up with an equation that would fit it pretty well. And the factors are listed there, so age, weight, serum creatinine, and gender go into this particular equation. I'm going to go back one step here and highlight, highlight one thing that I forgot to mention. And so as we focus on older adults, I'd like to highlight that in the MDRD equation in the study, patients greater than 70 years were excluded. And so not ideal when we're thinking about applying this to our older adult patients that we're caring for. And then in the Cockcroft-Gault equation, it's a small group anyway, so 249 patients to begin with, and only 25%, so 24%, less than a fourth of patients were 70 and older. So again, it makes us question the applicability or the accuracy when we are using these equations to estimate renal function in our older adult patients. All right, so in summary, or kind of to highlight some other points about these. So when do we use these different equations? And so we use estimates of creatinine clearance with the Cockcroft-Gault equation when we are drug dosing. So the FDA has traditionally required that drug dosing recommendations be provided for those with renal impairment and that be based on creatinine clearance. That is changing a bit, and so you'll see at the bottom of the slide here that it's newer, but the FDA is beginning to also require or allow that drug manufacturers can also provide recommendations according to GFR. I think the most important thing to note, and we'll go through a patient case at the end of the talk today, is that these are different measurements, and even for the same patient can provide you with different numbers and different results, which may result in different dosing recommendations. And so it's important to look at the dosing recommendations that are in the label and see if they're recommended according to GFR or according to creatinine clearance. But at this point still, most dosing recommendations, because of history or historically what has been recommended by the FDA are according to creatinine clearance. The MDRD, on the other hand, is used for chronic kidney disease staging. And so we look at GFR rates, and based on different cutoffs, that's how we assign the stage of chronic kidney disease that a patient has. So drawbacks. With both of these equations, you note, as I mentioned earlier, a primary component of those is the serum creatinine, so the blood level of creatinine. And unfortunately, there are many non-kidney related determinants of creatinine. So if you think of it as it being a natural byproduct of muscle breakdown, any extremes in muscle mass can have huge impact on the serum creatinine level that a patient has. And so this can cause perhaps misrepresentation of the patient's kidney function just simply because of the extreme in their muscle, not because of anything that has to do with their kidneys. There are terms, as you can see in the equations, which try to correct for some of these things. And so age-related changes in muscle are hopefully corrected for a little bit by adding age to the equation, gender as well, and race. However, again, when you have extremes, these equations may not be as accurate as we would like them to be. So, do we have other equations? And so, as I noted, the MDRD equation was the newest of the two that we've gone through, and it was developed about 20 years ago. And the answer is yes, there have been newer equations developed. So, CKD-EPI is a term that you may have heard of. These, what I have listed in this slide are two newer equations that have been developed by the Chronic Kidney Disease Epidemiology Collaborative. And so one in 2009 and one in 2012. The first, developed in 2009, essentially was based upon the same data points as MDRD, but just has used different mathematical modeling to try to come up with more accurate estimations of renal function. And you'll see it's from a more robust patient group, so 8,254 patients in the group that was studied. And then the 2012 studies came up with equations that involved a different marker than serum creatinine. So cystatin C is listed and is used in these equations. It is a natural protein in the body that is also excluded or excreted from the body by glomerular filtration rate, and it is not impacted by muscle mass. And so that is thought to be a huge strength when using this in patients that may have extremes of muscle, like we talked about previously. So, a question, I think, as we kind of get back to our focus today. So what do we know about utilization of these equations in the older adult population? And so I am going to highlight in the next few slides one study that looked just at that question and gave, I think, a lot of helpful information as we think through this. And so this was a study that was authored by a pharmacist, and I think coming from a pharmacist perspective, the focus was on drug dosing. And so as I've mentioned, because of historical FDA recommendations, official drug dosing is often based on creatinine clearance. However, we know in practice, oftentimes drug dosing is based on whatever kidney functioning level is easily present. So as I mentioned in charts, oftentimes the GFR is automatically reported when a serum creatinine is drawn, and that is according to the MDRD equation, so a GFR estimate. In contrast to, as I've mentioned a couple of times now, the creatinine clearance, which the dosing is based on. So there's some conflict there. And so this study was looking specifically in an older population at that controversy. So the study specifically looked at if you looked at the same patient and you calculated an estimated GFR using both the MDRD equation and the CKD-EPI equation, and then you estimated the patient's creatinine clearance using the Cockcroft-Gault equation. How do those different estimates of renal function compare to a measured creatinine clearance, which would be the gold standard that we would want to use when determining drug dosing? And all of the patients were older, and the mean age of this population was 81 years of age, which is very helpful for our focus today. So what did they find? They found pretty clinically significant changes, differences between the estimated renal function compared to the measured creatinine clearance. So when the MDRD equation was used to estimate GFR, this resulted in a result that provided a result that was 12.8 mil per minute greater than the measured creatinine clearance for a patient. The CKD epi performed a little bit better, but was still quite a bit higher than the actual measured creatinine clearance values. So 7 mils per minute higher than the measured creatinine clearance. Versus the Cockcroft-Gault, which was the closest of all three estimates, it was a -3. So it's estimated renal function 3 mil per minute less than the actual measured creatinine clearance. So the researchers took this study one step further. In the Cockcroft-Gault equation, one of the controversies is what to do when the creatinine of a patient is less than 1. And so what is commonly done in practice for older patients is that we would round up to 1. This is not something that was involved in the initial study that developed the Cockcroft-Gault equation, but in practice you'll find that this is something that's done. And the rationale behind this is that older patients have lower muscle mass, and so the fact that their creatinine is less than 1 must just mean that they have low muscle mass, and so to equalize this or to normalize this, we should just round up to 1 and perform our estimate of their creatinine clearance using 1 instead of their actual creatinine value. And so when the study, the researchers did this, they found that this was not helpful. So this practice of rounding the serum creatinine up to 1 provided a mean estimate of creatinine clearance for the group studied of 44 versus the actual measured creatinine clearance, which was 55. So a significant underestimate of the patient's actual renal function. And so as you can imagine in practice, this can lead to issues. So all of these misrepresentations of the patient's actual kidney function can lead to dosing errors, so either under or over dosing. And I would just note that there are other studies that have also supported that this practice that we see commonly done of rounding serum creatinine up to 1.0 is not helpful in providing a more accurate estimate of the patient's renal function. The last thing that these researchers looked at is how did these misrepresentations of the patient's renal function impact drug dosing? And so they came up with a list of hypothetical drugs and applied the renal function estimates and looked at how that would impact what dosing would be recommended for that particular patient. And essentially what they found is that the MDRD and CKD epi equations used to estimate GFR had a much higher disconcordance rate when compared to the measured creatinine clearance than the estimated creatinine clearance using Cockcroft-Gault. And so the conclusion to kind of summarize this is, again, it kind of gets back to that point that if the drug manufacturers or the label recommendation for drug dosing is made according to creatinine clearance, then we should be using estimates of creatinine clearance when we are making our drug dosing recommendations. And if not, we may be leading to overdosing potentially of these medications. So what about other equations? So I've gone through kind of the traditional, so MDRD to estimate GFR, the Cockcroft-Gault to estimate creatinine clearance, the two newer equations, CKD epi to estimate GFR. And so the question is, are there any that have been developed to specifically estimate renal function in older patients? And the answer is yes. So I will highlight these equations in this slide. So this is from the Berlin Initiative study. Two equations have been developed that were based upon a population of patients entirely 70 years of age and older, a group of 610 participants. And the equations themselves are listed here. The first, the BIS1, involves creatinine, age, and gender, as you can see. And then the second involves cystatin C. And so two different options for older individuals do exist. I would just say these aren't equations that you'll see in practice commonly, and myself, I looked at multiple different clinical calculators and apps to see if I could find this, and I was not able to find them. I was just with a Google search able to find a calculator that was able to perform this equation. So it's available. I think it's great to know about, but just to note that this is not something that's done commonly in practice at this time. So what do we make of all of this? So there's a lot of confusion, controversy, many different equations, a lot of shortcomings of all of these estimating approaches that we use. And so what I've outlined here, there were two really great articles in 2018 that I've cited at the bottom of this slide that I think did a nice job of pulling this all together, highlighting the confusion and the controversies, and really I think came up with some really nice take-home points that we can use when we are in practice trying to come up with accurate estimations of renal function for older adults. So the first I've mentioned a couple of times, but it is ideal if the estimation approach that you're using is consistent with what the drug dosing recommendation is based on. So if you're in the package insert, you're looking at the labeling for a medication and it says to cut the dose in half if the creatinine clearance is less than 30, for example, then when you're looking at your patient, it's really ideal that you are looking at an estimated creatinine clearance instead of an estimated GFR. The authors in this, one of these studies took a step further and stated that if you are going to use a GFR in place of a creatinine clearance, then it's important to make a modification so that you can at least be comparing equal units. And so as you'll see in the slide, and kind of anytime you see a GFR listed, it is listed according to mil per minute per 1.73 meters squared. And so if you're going to, again, use the GFR to equate to creatinine clearance, then you really need to do a correction factor for your patient's specific body surface area. And so you simply multiply the estimated GFR by the patient's body surface area divided by 1.73, and that will provide you an equal comparison. So that will give you your GFR in units of mil per min instead of mils per minute per 1.73 meters squared. So just a clinical pearl. Again, I think the first approach is easiest. Again, if you're looking at dosing recommendations based on creatinine clearance, it's best to probably use the creatinine clearance. But if not, this correction factor is something to consider as well. So the final point, I think, is the most important point of all, and it gets back to using clinical judgment. And so both authors of, or I guess both papers that I've cited in this slide came to the same conclusion that you really just need to think. So all of these different equations, no matter how accurate they are or how close we get to the measured renal function, they are estimates. And so we really need to be thinking, and you're going to have to make choices. And so what they highlight is that you need to stop and think about the risks and benefits of dosing according to the lowest estimate. So if you're going to be conservative in your estimate of the patient's renal function, then think about the risks and benefits of that. So with that, you're going to have a lower dose of medication. So if you're assuming that the patient has a low renal function, you're going to have a low dose of medication. And so your risk is that you might underdose a patient. In contrast, if you're going to use the highest estimate of renal function out of many options, if you estimate the renal function in many different ways using different equations, then you're at risk of overdosing. So keeping that in mind, and also thinking about which way do you want to go. And so an example of that, I think, is to kind of look at two different medication classes. So the first would be an antibiotic. And so if you think through that, if a patient has a really severe infection, the risk of that infection not being treated and progressing is really high. And so in that instance, you may want to err on the high side, and so go with more of an aggressive dose or a higher estimate of what you think their renal function might actually be, versus a pain medication on the other hand. So of course, patients don't want to be on pain, don't want to have pain. However, if you start low, you can always titrate the dose. And so that's something that you give a dose, be conservative, don't cause side effects, and then go up on the dose as you need. So again, it kind of comes back to your clinical application skills and really thinking through your goals, the risks and the benefits. And then the final step, kind of right along with that, is to monitor. So make sure that you're following up. And so it is that example of the anti-infective where you went on the high side of things, make sure that you're checking on things. So give the patient a call and ask them if they're having potential GI upset from having a higher dose of the antibiotic that's maybe not being cleared from their system as much as we predicted by their kidneys. On the other side, the pain example, give them a call in a couple of days and ask how their pain is doing and see if it is safe to titrate at that time. Okay, so at this point, I think there's a really good background. We've kind of covered the basics, gone through some research, and set ourselves up, I think, to try to apply these somewhat complex topics to an actual patient, so a patient example. So we will start with that now. So here is an example patient, SW, who presents today to your clinic where you're working for an annual exam. This is an 82-year-old female with a past medical history of type 2 diabetes, atrial fibrillation, hypertension, and GERD. You can see her current medications listed there. So amlodipine, 10 milligrams a day, metformin, 500 milligrams twice daily, metoprolol tartrate, 50 milligrams twice daily, ranitidine, 150 milligrams twice daily, and then warfarin, 2.5 milligrams daily. All right, so you have some objective information that you're looking at as well. So labs today, you can see listed there. So potassium, BUN, all normal. Serum creatinine, just a smidge on the high side, so 1.2. And there's the GFR. And this is exactly how renal function is reported in the charting system that I work with. And I think this is very common practice in electronic healthcare records. You'll see a creatinine if it's drawn. As I've mentioned a couple of times today, you'll have an automatic calculation of the GFR. So hers is 43. And it doesn't tell you what equation is used, but I think it's safe to assume that most automatic reports of GFR are using the MDRD equation to give you that estimate. So that's what we're seeing here. And that is the equation that's used at the health system that I work at. So that's what we're looking at today. Her A1C, hemoglobin A1C, is 7.2%. You see the urine test there, and so essentially, if it's been a while since you've looked at a microalbumin, this is simply showing you that the patient doesn't have any evidence of protein in the urine. So there's no other suggestion of kidney disease or kidney disease processes going on based on what you're looking at, so based on this urine test at least. In terms of vitals, the patient's height and weight is listed there, so the patient is just over 5 foot. Weight appears to be normal, blood pressure looks good, and pulse is normal as well. Okay, so we'll get to the heart of the visit. So the patient's chief complaint, she's very concerned about burning and tingling in her feet. And so after full evaluation and diagnosis from the physician, your team decides that the patient likely does have diabetic neuropathy, and it would be ideal to initiate the medication gabapentin, which is often a first-line treatment for this condition. So that's one thing that's going to come from the visit today. And then the next thing, so the patient has a question for you. What do you know about those newer blood thinners they advertise on TV like Pradaxa? Can I take that instead of my warfarin? So we've got 2 potential medication changes today, and so we need to think through these. And so the next steps, given the focus of our talk today, what I hope that you'll think about when these come up for you and your practice is the first question: are these medications eliminated by the kidneys? So I would suggest that anytime you're working with an older patient, given what we know about normal healthy aging of the kidneys, we need to be thinking about this. Even if there are no other disease processes occurring, the kidneys can have progressed to a point where we have to think about adjustments in drug dosing. And so yes, actually. So these, I will tell you, and this is something that you can look up if it's not something that you know, but both medications at question right now, gabapentin and dabigatran or Pradaxa, are eliminated from the body by the kidneys. And so this is something that we need to think about. The next question then, so is the patient's kidney function really at a level that I need to consider this? So her creatinine was only 1.2. That's very close to 1.0, almost normal. Again, is this something that we really need to be thinking about today? And for the reasons that I mentioned before, yes. With, again, healthy aging of the kidneys, you can certainly get to the point that even though there is no other active disease process going on, that the function has simply gotten to a point that the patient may not be able to eliminate the medication as they should, and that can result in issues. So we'll tackle this first one here. So let's look at gabapentin dosing. So if you pull this information up, again, drug dosing information according to renal function can be found in a lot of different places. So tertiary resources like Micromedics, LexiComp, clinical pharmacology, anything that you have access to like that, and also the package insert. So looking at the actual FDA labeling for the medication is another great place to find this information. So I've pulled that up for our discussion today for gabapentin, and as you can see in this table, we start to reduce the dose of gabapentin at a creatinine clearance of 60 even. And so that's almost no impairment in kidney function at all. So very likely that patients at a certain age are going to reach the point that we really want to think about lowering the dose of gabapentin. And so you'll look there, we've got different dosing recommendations according to 4 different categories of creatinine clearance. And so we'll need to really look at that to come up with our dosing recommendation for today. And so the thing I want to highlight, I've touched on this a couple of times today, is that this is according to creatinine clearance and not GFR. And so this is going to take a little bit of thinking on our part because as usually is done in practice and as we have in our information for our patient today, we only have the GFR, the estimated GFR populated for us at this time. Okay, and so let's look at her level and ask ourselves, have we reached that cut point of 60? And given that her GFR is at a level of about 40, I'm thinking yes. So let's take the next steps here. So in this slide, I've brought up her labs again and highlighted her estimated GFR, which is at 43. And then below, I've kind of done some work for you. And so this would be the next step for you as a practitioner, taking it to the next level. And so what's kind of nice, and you can find some of these calculators, clinical calculators, medical calculators that will do this for you, is you put in the patient's information, their labs, their age, their weight, and you can get a series of renal function estimates according to all of the different equations that that particular calculator has. And so what I've done for you is 2 different estimated GFR measurements. So the one that was reported in the chart, as I've mentioned, is according to the MDRD equation. I went ahead and calculated the patient's GFR according to the Berlin Initiative, so the equation that is tailored specifically to older adults. And then I also estimated her creatinine clearance using the traditional Cockcroft-Gault equation. So there's some variance. 43 is the estimate from the MDRD equation, down to 40 with the eGFR equations specifically tailored to older adults, and then as low as 30.2 when we look at the estimated creatinine clearance. And that, I would argue, is a pretty clinically significant change, difference, which can definitely have impact on the dosing that we recommend today. I also took it one step further, and as was mentioned in one of my slides previously, if you are going to use the GFR to come up with a dosing recommendation instead of creatinine clearance, when the dosing is recommended according to creatinine clearance, and it's important to normalize that for the patient's body surface area. So I took that step, and that reduced her MDRD estimate to 38 and her Berlin estimate to 35. So somewhat closer, but still, as you can see in this particular example, the GFR estimates are overestimating what we came up with for an estimate of her creatinine clearance. So what do we do? So again, it kind of goes back to the recommendation that I've made multiple times throughout. It makes most sense if the guidance is based on creatinine clearance to use the estimated creatinine clearance. So in this example, I would suggest using our estimate of her creatinine clearance, which is from the Cockcroft-Gault equation, when we determine her dosing. And so for her, we are going to go with a creatinine clearance of 30.2. And that will lead us to look at the 2 highlighted columns here for her dosing. So she's right on the edge. So even though we've gone through all of this work, we've looked at multiple different ways of classifying her renal function, this is still a challenging process to come up with a specific dose that we feel is going to be best for this patient. So what do we do? Do we go with the more conservative estimate? So she's really close to 29 mils per minute, so we could stick to the 200 to 700 milligram single dosing guidance, or since she technically is within the 30 to 59 range, should we go a little bit higher? And so with this recommendation, we would be dosing her twice daily, and we could go up to 1,400 milligrams a day. Well, a lot of factors can come into this. The severity of pain, her ability to identify side effects. So this would be a discussion, and I think something that would involve a little bit more of maybe a patient interview and kind of some patient buy-in as well. However, I think another way to look at this when I'm thinking about single dose or twice daily dosing, if anything, it's likely with continued aging that the patient's function will likely go down just naturally. And so even at the next visit, you might find that she is well into the category of 15 to 29 mils per minute. And so although dosing can be adjusted readily, pretty easily, it might be more confusing or more challenging to go to twice daily to once daily dosing, especially if you have pain that you're treating. Gabapentin is something that works kind of over time. However, there may be a feeling of kind of satisfaction from the patient perspective when they're taking that dose. And so I can see in treatment of pain, it might be harder to cut back to a single daily dosing. And for that reason, I might start there since I know that that's likely the direction that we're heading for this patient. And so with those thoughts in mind and potentially many others that you could come to when talking to the patient, one possible plan could be to start at kind of a moderate dose, so gabapentin 300 milligrams just once nightly at bedtime. So what am I going to monitor? And this is where that Beers criteria can be really helpful. So the rationale talks about CNS effects. So central nervous system effects are what we worry about if we have overdosing of gabapentin in older adults. And from practice, I know that patients that take too much gabapentin can get very sleepy. And so that would be something that I would talk to the patient about to be monitoring for. It's another reason that it's really ideal maybe to have a once daily dosing regimen that we can just time at nighttime. So if we did happen to be a little bit too aggressive today, the patient will experience the sleepiness when they're supposed to be sleeping. For underdosing, of course, we'll look for lack of resolution of pain. And so this does take a long time to work, though. So that would be something that I would spend a great deal of time talking to the patient about and letting them know that this will take weeks to really have the full effect. We'll be checking in with you on a weekly basis, and hopefully with time, you will see improvement. But if there was no improvement at the 12-week mark, the 4 to 12-week mark, that might be the time to consider increasing the dose. Okay, so let's move on. We have that next question here. So that question about Pradaxa. So watching TV and saw the great ads about newer medications, and they want some information about that. And so just like with gabapentin, I've pulled the dosing recommendations. And so you'll see, again, we're right at that cutoff. 30 is the mark where we have to make a significant decision about how we're going to dose this patient. So if their creatinine clearance is greater than 30, our dose of this medication would be 150 milligrams twice a day. And if it falls to 15 to 30, then we have to dose, so 75 milligrams twice a day. This medication is used for atrial fibrillation. It's the common term for patient terms would be a blood thinner. And so we have really significant concerns. If we overdose things, we are very concerned about bleeding. If we underdose things, then we're concerned about the patient developing a stroke as a result of their atrial fibrillation. So in this situation, there's really no good way to go in terms of erring high or low on the dose. The other thing that I would note is that a very, very helpful component highlighted in the Beers criteria, which it's very small print, but you'll see some of the rationale is that dosing, the 75 milligram twice daily dosing for the 15 to 30 mil per minute group is based purely on pharmacokinetic data. So we don't have actual patient data to drive that, which can make us feel a little bit hesitant about recommending that dose for our patients. And so with this one, I'm not sure I feel comfortable with this medication. And so I might take a different approach. And so I might talk to the patient about their current therapy. I would discuss the pros and cons, our lack of experience and data with this medication in patients that are older with natural and kind of normal aging kidneys. We don't have a lot of information. And then I would address any concerns with the current warfarin regimen. So is there something that the patient is concerned about with what they're currently taking? Warfarin is a tried and true medicine that's been used in a lot of older adult patients and patients with kidney decline as well. And so really just addressing concerns. Maybe it's simply that the patient felt that this newer medication was better. And so talking to the patient about that might resolve any concerns that they might have. Unfortunately, a third step would be to look for alternatives. So are there any newer anticoagulants very similar to Pradaxa that aren't eliminated by the kidneys that we could suggest as an alternative? And unfortunately, there really aren't. So there are no newer oral anticoagulants that are completely, maybe removed by the liver or something else. All of them have renal dosing considerations and lack evidence of safety and efficacy at creatinine clearances of about 25 to 30, which is very close to what our patient is. Okay, so lots of work. We came up with some good recommendations, and so the question is, are we done yet? And so this is perhaps the last maybe take-home message, is that part of the job of renal dosing, or coming up with renal dosing recommendations for older patients, is anticipating issues. And so maybe you aren't posed with a question or a side effect or asked about renal dosing of a drug, but instead you're kind of combing the medication for this and trying to prevent future issues. And so that should prompt us to look at the patient's current medications. And so let's look. If I look at these drugs, so amlodipine, metformin, metoprolol, ranitidine, and warfarin, with time and practice and finding yourself doing this over and over, these things start to jump out at you. And so I know that amlodipine and metoprolol are not medications that require renal dosing adjustments, but metformin and ranitidine do have renal dosing considerations. And so this is a great time to take that extra step and make sure that the current therapy that we have is safe, or to preemptively make changes if needed. And so let's start with ranitidine. Just like the previous examples, I've pulled up the dosing recommendations. And so again, ranitidine is one of those examples where even at a relatively high creatinine clearance level, we still start to reduce the dose. So once the patient reaches a level of less than 50 mils per minute, we would cut back the dose, the max dose, to 150 milligrams once a day. And if you recall, our patient is currently taking that twice a day. This is a medication that was also pointed out in the Beers criteria, again, because it's so commonly used, and I think perhaps overlooked is the fact that even at, like I mentioned, very relatively high creatinine clearances, we still need to start cutting back that dose. The problems that we see with these medications, all of the H2RAs, so histamine 2 receptor antagonists, is that patients can become confused, and that's one of our most significant concerns in an older adult, is that we are adding to any confusion or difficulty that they're having with mental cognition or mental function. And so this is a significant concern. And so again, for the patient, I pulled up her data, and we're looking at both her eGFR and her creatinine clearance. And this guidance is as usual according to creatinine clearance. And so I would recommend that we should half her dose. And so the recommendation today would be to, instead of taking 150 milligrams twice daily of ranitidine, consider cutting back to once daily. Okay, the final example here is metformin. So metformin is one of those that's not identified in the Beers criteria, and I think it's because it's pretty widely known, and in the past was probably over-adjusted for renal function, meaning that doses were reduced or it was stopped in patients when it really didn't need to be. Our concern with metformin is that if it builds up in patients with reduced renal function, that it can cause something called lactic acidosis, which is extremely rare, but extremely serious. And so guidance used to be to cut back or stop it at really early levels of kidney function, and with research and time, we've learned that we can be a little bit more liberal with our usage of metformin because this side effect is so rare. And so what I like to highlight about this medication is that this update came from the FDA somewhat recent. So I believe it was 2015 or 2016 that this new dosing guidance came out, which was, again, a little bit more liberal in terms of who we can use metformin safely in. And it is based on eGFR. And so I've highlighted that in these boxes. And essentially, we don't want to use metformin once the GFR falls below 30. We wouldn't want to start a patient on a new regimen of metformin if their GFR was between 30 and 45. However, if they're already on the medication and their GFR falls below 45, then we can reconsider, but the medication can still stay on board. And so if we look at our patient's data, again, her creatinine clearance is pretty low at 30. However, her GFR is fine. It's at 43. And so according to this guidance, you could interpret that her metformin at this point really is safe to continue. So in contrast to the other examples that we've had so far, in this example, I would say that we wouldn't necessarily need to do anything because her GFR is at a range that is safe to continue her metformin therapy. Having said that, you certainly could have that discussion. So we're looking at box 3. And so in patients taking metformin whose eGFR later falls below 45, assess the benefits and risk of continuing the treatment. And so you could talk to the patient about this very rare but serious side effect and ask the patient how she feels about that. Her A1C, if you recall, was 7.2%, and an 82-year-old, there might be a consideration of maybe stopping therapy and allowing that A1C to trend up a little bit. And so this would be an opportunity to discuss care with the patient. Having said that, according to the guidance and based on her GFR, we would not necessarily need to make a change in her dose today. Okay, so possible plan, as I've kind of outlined, with regard to these last two medications, we could consider decreasing ranitidine to 150 milligrams once a day. With this, I would monitor for GERD symptoms. So if we're backing off of therapy, and that's what this is used for, ask about heartburn, maybe follow up in a week or two to ensure that she hasn't suddenly developed more heartburn symptoms. And then again, the overdosing that we're concerned about would be the confusion, the central nervous system effects that we see with these medications. For metformin, if we do continue that, have a good education session with the patient, what to look for in terms of serious symptoms of lactic acidosis, and then also be watching for other factors that would elevate risk for lactic acidosis. So these would be things like heart failure, respiratory illnesses, that type of thing. Okay, so I think this slide kind of sums this up. So in the left-hand column, this would be the patient's medication list if we didn't consider her kidney function. So if we looked at her creatinine in the chart, it was 1.2, and we thought, oh, it's nothing, it's just aging, and we didn't take it a step further. Her medication list today could be the addition of dabigatran at a full dose, 150 milligrams twice a day. Her gabapentin, a normal starting dose for that for diabetic neuropathy would be 300 milligrams 3 times a day. And then the ranitidine would be left unchanged, so 150 milligrams BID. And my pictures hopefully show you my concerns there. So with the Pradaxa at full dose, I'm worried about a stroke. I would be worried about a stroke, I guess, if we had gone the other way with dosing, if we had underdosed. At this dose, I'm concerned about overdosing, so potentially bleeding concerns. With gabapentin, as I mentioned, we're most concerned about sleepiness, so at that high dose, I'd be worried that the patient would be very drowsy. And then with the ranitidine added to the gabapentin, we have potential concerns with confusion. And so this could leave the patient not in a great place. Versus our adjusted dosing, so we have the gabapentin dose down to just once daily, hopefully helping with the neuropathic pain that she's experiencing but not causing any sedation. Ranitidine, we've cut down the dose to hopefully prevent or even correct some small signs of confusion that she may have already developed, and we're just sticking with warfarin, which we can monitor and hopefully keep at a safe level for her to prevent strokes and bleeding symptoms. All right, so my final take-home points. So the first thing I would suggest or stress. So it's important, I think, to avoid dismissing renal function decline in older adults when you are determining medication doses. Yes, it's true that perhaps we don't have real concerns for progression to dialysis or complications of renal function. However, in almost all older patients, we need to be thinking about our medication doses and backing off when renal function reaches a level that requires us to do so. Second, identify renally eliminated drugs and adjust doses before problems develop. And so take a look at that list a couple of times in the Beers criteria and start to get good at identifying these or having these meds kind of jump out at you when you see them on a list of an older patient that you are caring for. Base dosing recommendations on GFR if that's what the label suggests, or creatinine clearance if that's what the guidance suggests. Use clinical judgment to weigh risk and benefit of conservative versus aggressive dosing for specific medications and indications. So we've gone through, I think, a couple of really good examples to highlight that. And the final thing, and I think this is important for all that we do for patients, is to make sure that we're monitoring. So educate patients about signs and symptoms of overdosing, so side effects, and then underdosing, which would be lack of treatment of their indication. And with that, I would just ask you to stay tuned for the next lecture in the geriatric lecture series. Thank you.